Okay, great. Okay, good morning and good evenings. I'm PY Cho and my colleague Junior 2. We both will moderate this webinar together and welcome to ICC webinar today. Uh, Today, our presenter is Professor Kamochi. Kamochi is a MD, DDS, and a PhD. Professor Kamochi complete this degree at the Tokyo Medical and Dental University School of Dentistry, Graduate School, PhD, and at the Nagasaki University for his MD. Currently, Professor Kamochi is the chief of Department of Plastic and Reconstructive Surgery at Shizuoka Children's Hospital, Japan, and also the director of CLEP and the Craniofacial Center at Shizuoka Children's Hospital. Professor Kamochi publishes several peer-reviewed papers in the field of first brachial cleft, craniosynostosis, cranioplasty, ear deformity, and congenital anomalies. In 2019, he published the article Development of Multidirectional Cranial Distraction Osteogenesis, MCDO, for the treatment of craniosynostosis in Journal of Craniofacial Surgery. Today, Professor Kamochi will introduce the application of MCDO in various types of craniosynostosis. Two good friends are invited to the panel. The first one is Dr. Tin Chen from Chang Memorial Hospital, and the next is Dr. Jordan Stenberg from Florida, United States. Welcome Professor Kamochi's presentation. So please.
Thank you very much, Dr. P.Y. Cho, for your kind introduction. And I'd like to appreciate that I have an opportunity to give a presentation today. I'm very great honored to be here and make my presentation to share my experience. Okay. Today, I would like to talk about multidirectional cranial destruction osteogenesis MCDO technique for the treatment of various types of craniosynostosis. I have no financial conflict and interest. Taiwan, along with South Korea, is Japan's closest neighborhood country, and it holds a special place in my heart. That's because 45 years ago, I lived in Kaohsiung City for 3 years from the age of 2 to 5. I was very young, so I have very few memories of living in Taiwan. I heard from my parents that the people in Taiwan were very friendly and we had a wonderful time there. This photo was taken with my family at the renowned Kaohsiung Temple. The boy wearing the red shirt and pants was me at 5 years old. 35 years had passed. I was fortunate enough to revisit Taiwan about 10 years ago. It was for the Chang Forum, 2013. I enjoyed my time there very much, and I took a picture with Professor Yuri Chang. I also attend the Chang Forum, 2018. 5 years later, I had a fantastic time once again. The CMFS Korea 2023 conference that takes place in Seoul this past April was very really valuable. I met many CMF surgeons here. Because of the connections made at this conference, I am now giving a presentation here. I'd like to express my gratitude to Prof. J.W. Choi for inviting me to CMF Korea and to many CMF surgeons in Korea. Thank you very much. By the way, Shizuoka Children's Hospital is located in Shizuoka City, Shizuoka Prefecture, Japan. Shizuoka Prefecture is situated in the central part of Japan. Shizuoka City is in the middle of Shizuoka Prefecture. In the east part of Shizuoka Prefecture, you can see Mount Fuji, which is the most famous mountain in Japan. Aerial view of Shizuoka City. Shizuoka Children's Hospital is located in the northeast of Shizuoka City. Yep, Shizuoka Children's Hospital. This is a picture of my hospital. Shizuoka Children's Hospital is a full service facility that offers comprehensive healthcare service for children. Our hospital has set up a cleft and craniofacial center for the treatment of craniofacial anomalies in newborns through growth completion. Today, I'd like to talk about craniosynostosis and these children with craniosynostosis. Craniosynostosis is a condition in which abnormal fusion of the sutures results in different skull shapes and sometimes decrease intracranial volume and increase intracranial pressure. The aim of a treatment is to achieve a suitable intracranial volume and to normalize the shape of the head. There are many methods for the treatment of craniosynostosis. I think that the methods that efficiently expands the cranial volume and facilitates the adjustment of cranial deformity, the cranial morphology, is preferable. Today, I'd like to talk about the treatment of craniosynostosis using the MCDO technique at Shizuoka Children's Hospital. The MCDO technique is a minor procedure that is only performed in 4 to 5 hospitals in Japan, and due to issue with tools such as distractors, medical facilities outside Japan haven't been performing this procedure. I've experienced treating almost 80 cases of MCDO, and most have led to excellent outcomes. I aim to share this knowledge with others and advance craniosynostosis treatment in the future. These are the outlines for today's presentation. The first is treatment methods for craniosynostosis at Shizuoka Children's Hospital. The second is the surgical treatment and treatment process of MCDO technique. The third is the disadvantage and the complications of MCDO technique. And finally, there will be case presentations. First, treatment methods. Surgical treatment for craniosynostosis may vary by center, but generally falls into 3 categories: destruction osteogenesis, strip cranioectomy, and calvarial bone remodeling. And destruction osteogenesis can be classified as front orbital advancement, FOA, posterior cranial bone destruction osteogenesis, PVDO, and MCDO. Our center, we use 3 methods for surgery: MCDO, strip craniectomy, and calvarial bone remodeling. We choose which method to use based on the patient's condition and when the surgery will take place. We use the MCDO technique to treat all types of craniosynostosis in patients over 5 months old, except for metopic synostosis. For infants younger than 4 months with single suture synostosis, we perform strip craniectomy followed by helmet therapy. To treat metopic synostosis, we opt for cranial bone remodeling. MCDO technique is cranioplasty developed by my mentor, Dr. Yasushi Sugawara, This technique was also published in PRS 2010. MCDO technique is one of the methods of destructive osteogenesis. The skull is osteomized into multi-bone pieces, which are then pulled up using a multidirectional external destruction device. The multidirectional external destruction device is composed of transparent plastic frame, anchor pins for securing the frame to the skull, traction pins for pulling the bone pieces up, and the destructor fixed to the frame. Two plastic frame variants exist, the MCDO type and the MCDO T type. Section frame. We select the frame based on the patient's skull deformity. With the MCDO type frame, we can treat the front half of the skull. And with the MCDO T type frame, we can treat the entire skull. Here are the numbers of the craniosynostosis patients at our hospital in the past 5 years. There were a total of 45 cases. 13 cases were syndromic, and 32 cases were non-syndromic. In the syndromic cases, Crohn's syndrome was present in 7 cases, Hyper syndrome in 3 cases. On the big side, 2 cases, and Saito-Chotsen syndrome in 1 case. In non-syndromic cases, Hideaki are most common with 13 cases. Unilateral craniosynostosis with 5 cases, bilateral rhomboids and Hideaki with 4 cases, bilateral coronal and Hideaki with 3 cases, and bicoronal synostosis with 2 cases. 1 case of metopic synostosis underwent cranial bolt remodeling. The cranial deformity was limited to the forehead and did not require additional cranial content volume. Cranial bolt remodeling was selected as a procedure of choice. 1 case of the 3-month-old patient with Hideaki was treated with a strip craniectomy followed by helmet therapy. The remaining 43 cases were treated using MCDO technique. Okay, second surgical technique and the treatment process, MCDO technique. 3D model simulation. We designed a bone cutting line on the deformed area of the skull using a 3D model. In the case of symmetrical head deformations, we use a model where both bone and soft tissue were evenly represented across a midline. Surgical technique, surgical position. If orbital bar is necessary, supine position is preferable as it facilitates easier osteotomy of the orbital bar. If an orbital bar is unnecessary, a sphinx position is preferable as it facilitates easier osteotomy of the entire skull. Surgical technique. 1 approach is a video captured from above with an overhead camera. Bicoronal approach is performed above the periosteum, like this. We use a coronal needle. Number 2, drilling for anchor pin holes. 4 or 5 screw holes for anchor pins were drilled into the temporal bones, guided by the template holes. And okay. The design of osteotomy line. In reference to the incision line designed with a 3D model, we designed the osteotomy line. We make 1 or 2 holes in the single piece of bone. or osteotomy. The skull is osteomized in small rectangular pieces. The individual bones are not detached from the dura mater. Orbital bar osteotomy is performed by a plastic surgeon, while other osteotomies are performed by a neurosurgeon. The traction pins are fixed in the bone pieces. The anchor pins are fixed in the temporal region where the hole have been drilled using the template. All the pins are fixed. Closure of the surgical incision close the skull flap, while the head of the traction pins and anchor pins penetrate through the scalp. The wires were secured in the traction pin holes. Closure complete. Prefixation and wire adjustment. The frame is fixed on the anchor pins in the temporal bone. The wires are passed through the holes in the frame so that the bone pieces can be pulled in the appropriate directions. This direction is very important. Fixing the wire to the distractors. The wires are fixed to the distractors attached on the frame. The treatment process of MCDO technique. Destruction was initiated 5 days after surgery. The bone pieces were pulled up by wire as a result of activating the distractor. Typically, the activation period lasts 10 to 14 days. The consolidation period is approximately 30 days. This period can be managed as an outpatient. The frame and all pins are removed in 10 minutes under general anesthesia without any incision. The treatment period is approximately 50 days. This is moving of this destruction process. Pain is minimal and the procedure is not very stressful for the patient. Destruction is performed once a day at a rate of 1.5 millimeter, and the entire process takes about 5 minutes. The frame is transparent, so the destruction can be done while visually confirming the head shape. Okay, number third, advantage, disadvantage, and the complication of MCDO technique. MCDO technique has both functional and aesthetic advantages. Functional advantage. The expansion efficiency of intracranial volume is relatively good. The MCDO technique, which increases surface area, is twice as efficient in cranial volume expansion as a unidirectional destruction technique, such as PVDO, which only increases flat area. It is possible to perform a complete total cranioplasty without creating any dead space. Aesthetic advantage. It is possible to create cranial morphology by extending in multiple directions. Head shape are easily checked by directly observing through the transparent frame. This advantage of MCDO technique, the frame must be worn for a long period, approximately 50 days. And the penetration of the pins through the scalp can result in scarring. Perioperative data and complications of MCDO technique. The post-operative clinical course was eventful in all cases. There are no neurologic findings and meningitis and liquid fistula. The amount of blood transfusion range from 4 to 1,260 milliliter per kilogram body weight, means 36.2 milliliter per kilogram. The mean surgical time is 306 minutes. And MCDO technique is a little bit invasive. Pin complications of MCDO technique. Minor pin tract infections occurred at the site of the anchor pins. However, they were all healed with daily sharpening or maintaining cleanness. Loosening occurred in 19 of 343. 5.5% anchor pins loosening occurring in 38 of 980, 4.1% traction pins. This did not cause any clinical problems. Short summary. The MCDO technique is a cranial ball destruction technique in all directions. Almost all types of head deformities can be treated. It is possible to effectively enlarge the entire cranial vault. Okay, case presentations. Case 1, Synostosis. This child is 1 year and 4 months old male with Synostosis. There are different symptoms of Synostosis: narrow elongation skull, narrow and low occipit, and temporal pinching, and sagittal ridge, and frontal bursting. These preoperative 3D MRI, we can see the presence of Synostosis. And these are 3D image after the destruction have been completed. The MCDO technique is the only method that allows extension in the direction of the vertex, and it's very useful for the treatment of sagittal synostosis. The cranial morphology has improved like this. This is a photo taken 1 year after the surgery. These are comparisons between the pre and post-operative photos. The head shape has improved. But case 2, this child is a 10-month-old male with right coronal synostosis. Pre-operative photo, we see marked asymmetry of skull, orbit, and face, with contralateral frontal bossing, ipsilateral distortion of the superlateral orbit. Preoperative 3D MRI, unilateral coronal synostosis can be observed. We can see an asymmetric shortening in the anterior-posterior dimension. These 3D CT image after destruction is complete. The position of the orbital bar is located more superior than the intended target position. Adjust the direction of the orbital bar direction and perform additional direction. The MCDO technique fitted the external fixation method allow for a change in the direction of destruction during the excitation period. These are post-operative photos. The head shape has improved. Case 3, left rhomboidal synostosis, 4-year-old male. Yes. Preoperative 3D CT, left rhomboidal synostosis can be observed. We can see that the deformity includes ipsilateral mastoid bossing and compensatory growth across patent contralateral rhomboidal suture, resulting in the parietal bulge on the unaffected side. This is a 3D CT image after destruction is completed. Pre and post. The cranial morphology has improved. And this is a photo post-operative day 1.5 years. There is a compare between the pre and post-operative photos. The head shape has improved. Case 4, bicoronal synostosis, 8 months male. With a severe brachycephaly, and these 3D CT image before surgery. Bilateral coronal synostosis can be observed. This is a post-operative 3D CT. Comparing before and after the surgery, we can observe an improvement in the cranial morphology. And these are comparisons between the pre and the post-operative photos. The head shape has improved. Case 5, bilateral rhomboid and sagittal synostosis, BLSS, 6 months male. This child showed typical symptom BLSS, front bossing, severe narrow and low occiput. Bilateral rhomboid and sagittal synostosis can be observed. by 3D CT image. This is a 3D CT image after destruction. It's complete. Pre and post. Compared before and after surgery, we can observe improvement in the cranial morphology. These are photos taken 1 year after the surgery. These are comparisons between the pre and post-operative photos. The head shape has improved. Case 6, bicornal, sagittal, and right rhomboid synostosis, 1.5-year-old female. This child has a severe asymmetrical head deformity. These are 3D image before surgery, and the bicornal and sagittal and the right rhomboid synostosis can be observed. These are after destruction 3D CT. Comparing before and after the surgery, we can observe an improvement in the cranial morphology. These photos taken 2.5 years after the surgery. These are comparisons between the pre and the post-operative photos. The head shape has improved. Case 7, shunt-induced synostosis, secondary synostosis, 2-year-old male. This is a severe head deformity, and we can see these are marking. This is a 3D CT, synostosis and the BP shunt placement, and this marking is there. MCDO technique like this, and this is a activation period and consolidation period. Yes, after complete of the destruction. MCDO is also possible to destruct bone fragment in which the BP shunt is placed. This is a 3D CT scan taken incidentally due to the head injury, and a post-operative day, 3 months. Bone formation is confirmed 3 months after surgery. Pre and post-operative 3D CT. This is photos post-operative year, post-operative 4 years. These are comparisons between the pre and post-operative photos. Case 8, Crusoe syndrome, 4 years old male. Pre-operative photos and pre-operative 3D CT. We can see a bicornal and sagittal synostosis and distal marking. Post-operative photo or 3D CT. The cranial morphology has improved. Post and pre, it is possible to confirm the subarachnoid space in the CT image taken after the destruction. Post-operative 1.5 years photos. This is a comparison between the pre and the post-operative photos. The head shape and the impression around the orbit have improved. Case 9, Apert syndrome, 9-month-old male. There is a photo, preoperative photo. There is a photo, preoperative 3D MRI, and this is a postoperative 3D CT. Pre and postoperative scar. It's there. Postoperative months, 8 months. Pre and postoperative 8 months. Okay, summary. I introduced the treatment for craniosynostosis using the MCDO technique in Shizuoka Children's Hospital. The MCDO technique is useful in treating craniosynostosis. Thank you. 谢谢.
Thank you, Professor Kamochi, for your very in-depth explanation of the MCDO technique. And also congratulations on the amazing results. I think we're all very surprised with how well you can make those craniosynostosis patients turn out to be. So congratulations on the results. Next, I'd like to go ahead with the panel discussion. So first, I'd like to invite Professor Tintin Lu for some comments. Professor Lu, you're on mute.
Hi, Professor Kamochi. Thank you for your excellent surgical result. I think
Thank you.
This method is very useful for those patients with like pansynostosis. It can really expand a lot. I only have a question is who will do the turning like every day? Is the nurse will do the turning or the doctors will do the turning, like turning the...
By doctor.
Oh.
By doctor. Once a day.
Yeah.
Yes.
Because you like the doctor have to decide where to be more and where to be less.
Yes, absolutely, yes.
Yeah, I think that's all the result. They looks beautiful.
Thank you. Yes.
So do you have like a similar device for the mid face? Because it seems that you do the head, but it seems to be maybe you have a like the similar device for the mid face.
Oh, actually, MCDO device combined with mid face destruction is there. Yeah. But like yes, but it is same as a Halo device. This portion is same as a Halo device.
Okay, maybe next time you can introduce the device to us.
Thank you. Okay.
Thank you very much.
Thank you.
Thank you, Professor Lu. Next, I'd like to invite Professor Steinberg.
Hi, good morning. Thanks so much for your presentation. And
good morning. Thank you.
Morning. Nice to meet you in Korea, and then also again this morning. You know, it's very interesting. This month in the Plastic and Reconstructive Surgery Journal, there's a big debate about the internal versus external distraction systems for the midface, just as we were mentioning. And, you know, some of the disadvantages for the external systems are things that, you know, some of which you've mentioned, but I wanted to ask a little bit about it. For this external frame, how do the baby, can you talk a little bit about how the babies sleep, and how much questions do you get about, you know, traumatizing the device, or have you seen that?
Okay, the child is asleep as normal. It's a very, there is no trouble in sleeping. It's okay. Yeah, and if elder child, they are running with a helmet and accidentally hit the helmet. Yeah, the broken helmet is there, and we have to remove the helmet a little bit earlier.
Okay, yeah. So it's not so common.
Yeah.
Yeah. Okay. And then the way that everything is working, it seems that, again, that you get a net expansion. But for some of the types of synostosis, you know, we may make some areas smaller with a remodeling, like a sagittal, you're reducing the AP and widening the back. So with this system, you only can make things bigger, but not smaller, correct?
Yeah, we can do a small, we can do a small shape. We can make a small shape because we usually suture bone fragment from the bossing and the oxyburu and the tighten and bone we expand here. Yeah.
Do you have any ways now that you are making a guide or planning the movements on the computer before, or is it all by eye?
All by eye, actually, because cranial base shape is different from all patients. So ideal shape is different from each person. So we check from my eye and good shape make. And we take CT scan after destruction. We also check the intraocular volume. The goal was volume is 1,500 cc.
Okay. And the last question I had was about bone thickness. So the same thing with the patients for mid-phase with the rigid external distractors. Sometimes the bone thickness is a limitation. And in the syndromic case, you showed even the anchor pins into the temporal bone where it's sometimes a lot of holes and very thin. So are there patients where the bone thickness is not adequate enough to do this?
Yeah. Yes. It's a very important bone thickness, the temporal region, and we use absorber plate to here and strength anchor pin fixation. Yeah. So we can do during anchor temporal region, and I think it's a very thin. We can use a resource plate and fix a helmet.
Thank you.
Thank you.
Thank you, Professor Steinberg. Next, I'd like to invite Professor Low for some comments.
Hi, Dr. Kamochi. Thank you for your presentation. It's really nice result. And but I do have some question that I would like to ask your opinion. The first one is, do you need to do overcorrection, especially in the disease side? For example, if you have one region that has restricted growth and you do destruction, do you need to destruct this side, overcorrect it, or you just create a skull shape that is normal?
Yeah, I usually do overcorrection. CT check 1,050 100 is volume of age at 5-year-old. It's a very overcorrection because MCDO technique and same as other technique and cause pansynostosis, secondary synostosis. So I have to do overcorrect intraocular volume.
Okay. For example, if you have a unicoronal synostosis, you show a case. Do you need to destruct this area more expanded or just the same as the other side?
Oh, a little bit overcorrection.
So you do overcorrection
Yeah,
on
yeah,
the disease side.
yeah.
Okay. The second question is that when you introduce a special technique, people would very likely ask, what is the comparison with the other technique? Do you have the planning to compare your technique with other technique?
At attending in my hospital. Sorry.
No, I mean, when you introduce a treatment technique, okay, for example, your MCDO technique, and other surgeons do other like cranial remodeling treatment method, or in your how you have any plan to compare the several different technique advantage and disadvantage?
Oh, yes. Yes. Of course, I told the patient advantage and disadvantage, but I have been done cranial remodeling and other technique, and I prefer to use MCDO technique. Yes.
Okay.
Sorry.
Then and then maybe the the last is the comment that I would very eagerly to see if you continue to follow up your patient and to see what happened, the cranial development, because we always treat the baby at the smaller age, and when the baby grow up, especially when they reach skeletal maturity, there's something else happen, and the long term follow up after a cranial plasty really is a very interesting topic. Then, and I hope that you can continue to follow up your patient.
Yes. Yeah, I always follow up from to adult. Yeah, I want to touch up surgery and so on. Yes.
Okay. Okay. Thank you very much.
Thank you.
Thank you very much, Professor Low. Next, we would like to go to the Q&A session. So the first question is actually a question from Dr. Athanas, and the question is that, have you ever tried to increase your rate by more than 1.5 millimeter per day?
Oh, yes, I have. Yeah.
And is there a reason why you said that you usually do 1.5 millimeter?
It's we check the shape of the head and oh, fragment. This fragment is more destructor is better. I think it's a little bit destruction than others.
Is it possible to increase the distraction rate to 2 millimeter or more?
Yeah, yes.
But if we do so, is there any possible complications that we might be faced with?
Yeah, I think 2 millimeter is okay. Yeah.
Oh, well, what is the maximum number of
maximum number?
Yeah, distraction.
Maximum number. Yeah, maximum number. Yeah, 2 to 3 millimeter is okay, I think.
Okay. And our next question is from Dr. Honda. And the question I know Dr. Steinberg has already asked you a little bit about, but I was wondering if you could expand a little on it. The question is, how do you make a decision for the total amount of distraction?
Oh, I'll make a description.
Yeah. How do you make the decision for how much you need to distract?
Okay.
Since
okay. It is easy to MCDO technique, compared to the conventional cranioplasty because we can check shape and gradually expand the head. So it's easy. And different goal is volume of the intercranial volume. Yeah, I think I usually do 1,500 cc.
Okay. And actually we have another question from Dr. Sporty. And the question is there an ideal age for this procedure?
Ideal age is 8 months to 1 year. Yeah.
Is there a reason for this?
Yeah. It's a temporal lesions bone. Yeah, it's a thickness of a temporal lesion. Yeah.
Okay, thank you. And that's all we have for the Q&A session. So we'll hand the mic over back to Professor Zhou.
Thank you, Junior. And thank you, Professor Kamochi, for your wonderful presentation to introduce new, I think it's not really new, but it's already be applied in your experience to treat different kind and the different and the various kind of synostosis patient as well, and with a very nice outcome. Really appreciate. And of course, like the Professor Steinberg's address in his questions, in this September's month of the PRS really has one article to debate external and internal application for those distraction in patient with the synostosis one. I think there is always not have a very good answer for that. Even, yeah, maybe we have one case is just performed 1 month ago for Professor Low, that is the Apert syndrome as well. And then we performed the 4-3 distraction and with external application too. Yeah, so we are always trying and we are always learning. So that's why we are always need to do some research and has advanced our technique and always follow up our patient for 4, 5, 10, 20 years. Long-term follow-up is always our goal and our target to know which one is best for our patient treatment. Okay, I would like to always invite our participant and in front of you. I think some of our participants of ICC, they are probably on the way to Seattle now. Maybe or may they already in Seattle for the ISCFS and get used to the jet lag too. So never mind, we still have some very loyal and a very good friend and be here with us. Yeah, okay, before I will come and call of you, my friend, to have a group photo, I have one advertisement from Chang Memorial Hospital, want to share with all of my friends as well. Probably you can see my slide here. Yes, there is one of a master series course is a cadaver dissection course in the coming October, in October 14th and October 15th and 16th, and we prepared 8 cadaver the head to perform to show the facelift for those cadaver, and we can prepare some hand-on courses for trainee and for observer. And the other course is following by the first day of facelift, and that is the orthodontic surgery, two-jaw surgery. And these 2 master course was be performed by Professor Chang, and orthodontic surgery be performed by Professor Yuri Chang. And this two-jaw surgery, we prepare the same 8 cadaver head, and then we do the two-jaw, the 4-1 osteotomy, and BSSO with the genioplasty, and we introduce how to do fixation and how to design the planning for this jaw surgery. So always welcome. You can come over and we can see you in Taiwan. And please, if you have any problem or question, you can scan the QR code on the screen to know more information, and you can leave your message to us. We can answer for you too. So finally, I hope we can have all of you smile, and please turn on your computer. And I will count to 3, and please, we can take a photo. Okay, hello, Professor Sato, long time no see. Hi, hi, Daphne, and Professor Handa, EK, Professor Fayaz, and Dr. Shetty. Nice to see you here, and easy. 1, 2, cheese. Thank you very much for your coming. Actually, I think all the Chang'an team are ready to depart to Seattle too in maybe tomorrow. So maybe see you in Seattle soon. Okay, looking forward to your next coming to join. Our next topic will be presented by Professor Renzo Lo, 1st of October, and Professor Lo will demonstrate the cleft surgery for all of our friends. That is a very big impact, important video demonstrations prior to our Chang'an Forum too. See you. Good morning and good evening. Bye-bye. Thank you, Dr. EK. Thank you, King Chang. Thank you, Junior.
Okay, we'll see you
调时
tomorrow.
差，呀，调时差，今天不要睡好了。对啊。
不要吧，这样会不会太惨？Okay.
Okay, okay. Have a good
Tomorrow.
one.
Bye-bye.
Okay, bye bye. Bye.
Bye.